Hello friends, welcome to Studentel. Our topic for today is aggressive periodontitis and I am Dr. Salman Ansari, your mentor for today. First we'll start with definition. Aggressive periodontitis comprises of a group of rare, often severe, rapidly progressive form of periodontitis, often characterized by an early age of clinical manifestation and a distinctive tendency for cases to aggregate in families. Yes, how it differs from chronic periodontitis. So, here are the features. Age of onset. Generally, the patient in aggressive periodontitis is less than 30 years of age. Its rapid rate of disease progression, it is generally 3 to 4 times faster as compared to chronic periodontitis. Nature and composition of the associated microflora differs from that of chronic periodontitis. The microflora of aggressive periodontitis contains mainly Actinobacillus actinomycetum comitans, B. forsythus, Capnocytophaga species, and P. gingivalis. Alteration in the immune response, generally phagocytic abnormalities and hyperresponsive macrophages, is generally seen in aggressive type of periodontitis. Then familial history suggestive of genetic trait is seen in aggressive type of periodontitis. Then there is a disproportion between the amount of plaque and the rate of destruction in aggressive periodontitis. Now we'll see the clinical picture, how it appears. In this figure, you can see the deep periodontal pocket associated with first molar. After flap reflection, you can see the severe amount of bone loss. In this maxillary first molar, you can see the deep periodontal pocket, and after the flap reflection, the amount of bone loss. Generally, you can appreciate the thing that the local factors are not present in spite there is a deep periodontal pocket and such a large amount of bone loss. So such is the clinical picture of aggressive periodontitis. Generally, the aggressive periodontitis, it is classified as localized aggressive periodontitis. Earlier, it was called as localized juvenile periodontitis. And the second entity is generalized aggressive periodontitis. Earlier, it was called as generalized juvenile periodontitis, rapidly progressive periodontitis, and generalized early onset periodontitis, GEOP, generalized early onset periodontitis. Now we'll see the striking clinical features of localized aggressive periodontitis. Localized aggressive periodontitis is localized to first molar and incisor with interproximal attachment loss on at least two permanent teeth, one of which is first molar and involvement not more than two teeth other than first molar and incisors. Minimum plaque is present that rarely mineralizes, and this plaque, it contains increased levels of Actinobacillus actinomycetum comitans and P. gingivalis. The clinical picture shows that it lacks clinical inflammation despite the presence of deep periodontal pocket and advanced bone loss. Here you can see inflammation is not seen in spite of deep periodontal pocket present in first maxillary molar. Other clinical features of localized aggressive periodontitis are there is a distolabial migration of maxillary incisors which leads to diastema formation, increased mobility of incisors and first molars, sensitivity of denuded root surfaces, and deep dull radiating pain during mastication. This may lead to periodontal abscess and lymph node enlargement. Now I'll see the radiographic findings of localized aggressive periodontitis. There is vertical loss of alveolar bone around first molar and incisors, beginning around puberty and otherwise healthy individual. Here you can see vertical bone loss associated with first mandibular molar. The arc-shaped bone loss from distal of second premolar extending up to the mesial of second molar. Here you can see arc-shaped bone loss. These are the clinical diagnostic signs. The vertical loss of alveolar bone around first molar that begins around the puberty, otherwise in otherwise healthy individuals, and arc-shaped bone loss that extends from distal of second premolar till mesial of second molar. This is the OPG of localized patient with localized aggressive periodontitis. Here you can see the arc-shaped bone loss present in maxillary first molars and vertical bone loss seen in mandibular first molars. Now, clinical features of generalized aggressive periodontitis. Generalized aggressive periodontitis, this usually affects person less than 30 years of age, but patient may be older also. In contrast to localized aggressive periodontitis, patient with generalized aggressive periodontitis produces a poor antibody response to pathogens. Clinical features of generalized aggressive periodontitis are generalized interproximal attachment loss affecting at least 3 teeth other than first molars and incisors. Episodic nature of the disease. Episodic nature of the disease, that is, there is period of inactivity which may last to weeks, months or years. Then quantitatively the amount of plaque is inconsistent with the amount of periodontal destruction. Quantitatively, plaque contains high levels of Actinobacillus actinomycetum comitans, T. forsythia, which was also known as B. forsythia, and P. gingivalis. This is the clinical picture of generalized aggressive periodontitis. You can see there is a generalized bone loss including the molars, incisors, also the canine and premolars. Now we'll see the episodic nature of the disease. Episodic nature of the disease produces two different tissue response, that is destructive phase and non-destructive phase. Destructive phase, tissue appears severely inflamed, ulcerated and fiery red. Bleeding with or without stimulation may be present. Suppuration, that is pus discharge, is present, and active attachment loss and bone loss is present in destructive phase. In non-destructive phase, tissue appears pink with some stipplings, lack of inflammation, probing will reveal deep periodontal pockets, bone and attachment levels relatively are stable. Generally, there are some systemic complications associated with generalized aggressive periodontitis. Some patients with generalized aggressive periodontitis may exhibit weight loss, mental depression, and general malaise. Systemic conditions may predispose patient to generalized aggressive periodontitis. These includes chronic neutrophil defects and leukocyte adherence deficiency. The functional defects of polymorphonucleoleucocytes, monocytes, or both may be present. There is impaired chemotaxis and phagocytosis of neutrophils. Now we will move on to the radiographic features of generalized aggressive periodontitis. Generally, it ranges from severe bone loss affecting minimal number of teeth to advanced bone loss affecting majority of the teeth. Approximately 25% to 60% of osseous destruction takes place during the period of 9 weeks. Despite of the aggressive nature, some sites may show no bone loss because of recessive phase and destructive phase that alters. This is the OPG of patient with generalized aggressive periodontitis. You may see the large amount of bone destruction in first molars and incisors. Also, in contrary to localized aggressive periodontitis, there is bone loss seen in premolars also. We can't see bone loss in localized aggressive periodontitis in premolar area in localized aggressive periodontitis. Now we will move on to management of this aggressive periodontitis. We should keep certain therapeutic goals in our mind while treating the aggressive periodontitis patients. First of all, our aim should be to alter and eliminate the microbial etiology and which contribute to the risk factors of periodontitis. Our aim should be to arrest and slow down the progression of the disease. We should intend to preserve the dentition in comfort, function and aesthetic and to prevent the recurrence of the disease. We should also attempt for regeneration of the lost attachment apparatus. General principles in treating the aggressive periodontitis. Aggressive periodontitis is often associated with alteration in host defenses. Therefore, the factors that may contribute to changes in the defense system must be explored. The lack of strong association between plaque accumulation and disease severity in the aggressive periodontitis means that these patients are less responsive to conventional periodontal therapy. Surgery may not be advised in aggressive periodontitis until the infection is under control. Now we will see what are the treatment modalities in treating the aggressive periodontitis patients. The treatment modalities are divided under conventional periodontal therapy, non-surgical therapy, and surgical therapy. Not all cases of aggressive periodontitis may need surgical therapy, but most of them may need surgical therapy. Conventional periodontal therapy includes patient education, oral hygiene improvement, scaling and root planing, and regular recalls. The non-surgical therapy, it includes administration of local antimicrobials, local drug delivery, full mouth disinfection, and host modulation therapy. The surgical therapy, it includes resective surgical therapy or regenerative therapy depending upon the cases. First, we move on to conventional periodontal therapy. Conventional periodontal therapy, its outcome is limited and unpredictable in response. Extraction of hopeless teeth must be carried out in subsequent recall visits to avoid development of negative impact on the patients. The non-surgical therapy includes first antimicrobial therapy, that is systemic antimicrobial therapy. Because of the presence of AAC in the tissue, Aggressive periodontitis does not respond to conventional therapy. The pathogen remain in the tissue after the non-surgical therapy, which may reinfect the pocket. AAC present in the deep connective tissue, so to eliminate them, systemic antimicrobial or antibiotics is administered. Systemic antibiotics in conjugation with the mechanical therapy gives the favorable results. The antimicrobials, which is the first choice, is tetracycline 250 mg 4 times daily for 1 week. If no clinical improvement is seen, there is possibility that the strain contains tetracycline resistance. So, in that case, the combination of amoxicillin 250 mg along with metronidazole 250 mg is administered TDS for 8 days. The use of antimicrobial testing may be considered in cases of non-responding aggressive periodontitis. Second is in non-surgical therapy. Second is local drug delivery. Local drug delivery offers a novel approach. Smaller test dosages of tropical agents can be delivered inside the pocket. Side effects of systemic antimicrobial agents are avoided in this case. The different forms of localized drug delivery agents used in aggressive periodontitis are solutions like chlorhexidine and betadine, gels like tetracycline hyclate, chlorhexidine, and minocycline microspheres, fibers like tetracycline fibers, which may be resorbable or non-resorbable, and chips like chlorhexidine chips. Third is full mouth disinfection. Another antimicrobial approach for the Another antimicrobial approach in the control of infections associated with periodontitis are first given by Quernin et al. In 1915. It was full mouth debridement within 24 hours, that is in 2 appointments. In that, he used brushing of tongue with chlorhexidine 1% for at least 1 minute, mouth to be rinsed with chlorhexidine 0.2% solution for 2 minutes, followed by pockets irrigation with chlorhexidine 1%. The beneficial effects of one-stage full mouth disinfection probably results from the full mouth debridement within 24 hours rather than the adjunctive effects of the chlorhexidine. Last is the host modulation therapy in non-surgical periodontal therapy. A novel approach in the treatment of difficult to control aggressive form of periodontitis is host modulation therapy. In this, we administer sub-antimicrobial dose of doxycycline, that is 20 mg of doxycycline, along with mechanical therapy, that is scaling and root planing. This has given clinical improvements in generalized aggressive type of periodontitis as it improves the host response. It prevents the destruction of periodontal attachment by controlling the action of MMPs, that is collagenase and gelatinase, and thus improves the host response. Now we will see the surgical therapy. Surgical therapy, it provides access to the deep subgingival plaque and calculus. The surgical therapy, it may be resective surgery or regenerative surgery depending upon the need. Resective surgery, it aims in reducing and eliminating the periodontal pocket depth. It is difficult to accomplish if adjacent teeth are unaffected, as often seen in aggressive type of periodontitis. Therefore, a less ideal outcome must be taken into consideration before deciding to treat increased pocket depth surgically. Regenerative surgery. Regenerative materials like bone grafts, barrier membranes, or the combination approach or wound healing agents have been used in the regenerative treatment of aggressive type of periodontitis. Recently, bone grafts in combination with tetracycline powder have provided good results. Also, emdogain, that is enamel matrix protein, have offered benefits in localized aggressive periodontitis patients in the regeneration of cementum and new attachment. That was for all about aggressive periodontitis. Thank you.